we educate you on those policies and processes. And our intention and our goal today is to ensure that it translates to quality service delivery under the constituency. So with that, I would like to invite the Director General of the Edohic Health Insurance Commission, the distinguished Director General, the goal-oriented Director General. I would like to invite Dr. Mrs. Augusta Ikia Inaolo. Please come here around the
operate seamlessly. When claims are clear, payments are timely made, quality care is consistent and delivered, everyone benefits. Our enrollees receive the health care that they need. You are supported and rewarded for your service. And together we advance the health and productivity of Edo State in alignment with His Excellency Senator Monday Okpebholo's 5-pillar SHINE agenda, where healthcare is the second pillar, which focuses on expanding and upgrading facilities and making healthcare accessible to everyone in Edo State, no matter your status. Let us use today's engagement as an opportunity to strengthen our collaboration, enhance transparency, and resolve any operational issues, all with the shared goals of delivering exceptional healthcare services. Thank you for your continued dedication, your cooperation, your relentless commitment to the health and well-being of our people. I wish you a productive and impactful session. Thank you very much, and God bless.
This, I think that a round of applause is not befitting of our mission. Thank you very much. Thank you very much.
Thank you very much. Thank you, Gigi, for your impeccable opening remark. Now, as you go along, like Gigi earlier said, the commissioner is currently not here, so I'm very absent. But during the course of the training, I'm sure you will join us. Now, let me quickly take us through an introduction of the Edo State Health Insurance Scheme. Edo State Health Insurance Scheme was drafted in the year 2017 and was passed by law in the year 2019. In the year 2021, access to care began. And I say it with so much pride that a lot of the facilities we started in 2021 are still with us as partners today. So I think that is a state of pride and a state of growth. And please continue yourself all the In 2029 also, we had our first Edo State Health Insurance Summit, which we had a lot of engagements with other stakeholders that helped us improve on our processes. In 2020, we had our first study tour. We had our actuarial analysis that vetted our health plans alongside our benefits. In 2021, we started accrediting health service providers and we started with just 25 healthcare facilities across the 3 central. In that same 2021, enrollment began, and it was a massive enrollment across the 3 central districts at the same time. And when we started, it wasn't easy. It was something that had never been done before, but we were blessed to have an impeccable team who were willing to go out and show out. In 2022, access to care started and we started enrollment. As of today, we have over 276,000 enrollees across the 3 central districts. And please bear in mind that the scheme has been designed to cater for everyone, irrespective of the financial backing or capability. In 2025, our delectable and beautiful Director General, Dr. Mrs. Augusta Ipe Enamolo, was appointed as the new Director General of the Edo State Health Insurance Commission. Please can we give her another round? So like I said, Edo is represented across the 18 local governments. It will interest you to know that this training going on here is happening in Edo North and Edo Central. We are currently streamlining to ensure that everybody goes home with the same quality information. Next slide. In our 5 years worth in Edohic, this is what we have achieved so far. Like I said, when we started in 2021, when we started access to care in 2021, we started with just 25 healthcare facilities. And as of today, we have over 380 healthcare facilities across both primary, secondary, and tertiary level. Alright? We currently have a total of 208 PHCs under the scheme. We have 107 private and public general hospitals under the scheme, which it also includes diagnostic services, laboratory, pharmacies, and ambulatory services. So currently in 2025, like I said, we have scaled up massively, and that's why everyone is here. Now, we know that we have over 1,200 healthcare facilities in those states, but because of the criteria we have come up with, we are not able to accommodate all certain standard, and we expect our facilities are able to uphold that standard as we go along as partners. Alright, so with that being said, I would like to introduce the first facilitator of the day, so she can speak on the achievements and the gain of the Health Insurance Scheme now. With this, I introduce the Technical Advisor to the Director General, Mrs. Ifeyinwa Odungiyi. Alright, you're welcome.
The weather is a blessing, like the teacher said, and we hope by the time we're actually done with this session, we're going back with a renewed mindset, and we'll definitely put everything into practice for the good of all of us here. Okay, so I'm actually here to kick off from where Dr. Yuki stopped, and this is talking about basically our achievements and where we're headed to, and how each and every one of us is involved in making this whole project a success. Okay, so this is the outline for my own session, what we've done so far, strategic direction under His Excellency Senator Monday of Everyone's administration. That's where we're headed, and the provider's critical role in achieving universal healthcare coverage. How you all can make it happen within this sphere. Then we talk about the call to action, because there's definitely a call to action in all of this. So let's watch this brief Netflix.
I am Dr. Mrs. Augusta Ikpeanyahulo, the Director General of Edo State Health Insurance Commission. Our mission is to deliver high-quality, accessible, and affordable health insurance solutions that cater to the diverse needs of all Edo residents, ensuring no one is left behind in the pursuit of good health. Our vision is to create a future where every resident of Edo State enjoys seamless access to the quality healthcare, fostering a healthier and a more prosperous community. From mandate to monumental impact, this has been our role in Edo State's healthcare revolution. Our strategic objective, which is to strengthen the foundation of the Edo State healthcare system by reducing out-of-pocket spending and improving access to effective, efficient, sustainable, and quality healthcare services to every enrolled citizen of Edo State.
Good day, everyone. My name is Dr. Saiki Edo-Saidiayi. I'm the Director of Health Sciences and Standards for the Edo State Health Insurance Commission. So today we're going to talk about how we onboard and support facilities. So currently, we have created a structured onboarding process for bringing facilities on board the Edo State Health Insurance Scheme. We have ensured that the process is quite streamlined. It is a very easy and objective process that enables us to bring in every facility that meets our criteria. We also support facilities based on financial resource allocation. Now, facilities who are doing well and putting their weight tend to get more MDs assigned to them, and this kind of translates to financial support.
Hello everyone, I'm Femi Moye. I'm the Director for Customer Success Call Center Department of the Edo State Health Insurance Commission. I'm here to talk about how beneficial our health facilities has been in the course of this whole journey with our employees. We've gotten a lot of collaborative efforts, a lot of support from our health facilities. A lot of times our employees have to relate with these facilities, and many a times we've gotten a lot of good feedbacks from them, and we've also tried to play a very supportive role for Commission in helping these facilities and these MOBs navigate their way through receiving quality healthcare at their respective facilities. So it's been a very supportive and very collaborative relationship we've had with our health facilities, and we are really grateful to them for all the support and all the goodwill they've given the scheme in general. God bless everyone for that. Thank you. To bear witness to that, we have some testimonials and some of our employees have taken concerning their experience with their facilities on the school.
So just to let you know that these testimonials are life experiences. They're not made up. If we actually had the impetus to even put up videos, we would.
This is the purpose of universal health coverage, and you are the heart of it. Thank you very much.
So on that note, before I continue, we won't have achieved all that we have achieved without each and every one of you here. And so far so good. From the DG's office, resumption of office, within a short while, she's been able to achieve so many and silently bagging their words. One of which is the best health insurance and managed care government agency in Nigeria in healthcare and coordination management. So that was given to her in Abuja. Next slide, please. Okay, so these are part of our projects, enrollment of over 450 orphans from registered orphanages into the scheme. We have pictures of some of the activities that went on. We had so many successful outreaches. We've had on Children's Day, DG actually had it in our heart to, support not just enrollees, non-enrollees of Edo States to pay up their medical bills, and this was done strategically. We partnered with some facilities, and we had to get a queue of some certain information that made them qualify. Yes, so this is all part of their outreach. And next slide, please. Yes, so this one of the DG's visits to orphanages on Children's Day. She spent a moment with them, and she also played with them. You can play the video, please. Thank you very much. Okay, so this to show you how passionate the DG is about, reaching out to each and every single individual in Edo State, whether old, young, vulnerable, professional, whatever you call yourself in this space. Okay, so now we're definitely not working under pilot in Edo East. We actually have a mandate from His Excellency Senator Monday Ogbegolo, which is called out from his vision, which represents the new era, emphasizing the commitment to universal healthcare coverage that adopts a people-centered approach dedicated to ensuring that no resident is left behind in the pursuit of good health, in which the letter H stands for healthcare as a pillar in the SHINE agenda. I'm sure we all know what the Shine agenda is all about, and the H is very, very, it's a very, very sensitive area, which His Excellency holds at heart. Okay, a shift in strategy. We're looking at, from enrollment, not just enrolling individuals under the scheme, but we're looking at a situation whereby we're retaining them, and it's giving the residents of the state so much hope, so much faith in the system, not even now, but even beyond this regime. We're looking at beyond our previous focus, which was getting people in, and now we're now looking at a situation whereby they're not just getting in, but they're also receiving the best care ever, which our key focus areas are, looking at expanding provider networks. We're committed to expanding our networks to every corner of the state, so there are no restrictions on that in order to achieve what we have to achieve, ensuring that distance is not a barrier to care. We're looking at a situation whereby we are improving on our claims and care coordination. We're streamlining our processes. This has already kicked off to ensure timely payment and efficient pre-authorization, reducing administrative bottlenecks for you, the provider. And eventually, we are looking at a situation whereby we would eventually do that, the digital healthcare integration. We'll be looking at different solutions which will cushion some of the bottlenecks which we are currently experiencing in patient care management. Now, what's your role in all of this in achieving universal healthcare coverage? So for you, the provider, you are the first and most critical point of contact, starting from your diagnosis, treatment, and patient communication directly determine the quality of care the patient trusts in the scheme. So everything starts with you. For any enrollee and for every patient to even trust in Edohic, it has to start with the provider, meaning that you are a major and sensitive stakeholder in driving this for us. We're looking at a situation whereby, we're actually achieving you standing as a financial guardian in all this process by adhering to guidelines and protocols. You're ensuring that the scheme's sustainability is, stable. You're following through process, looking at the pre-authorization process, following the treatment protocols when it comes to prescribing, diagnosing, and prescribing medication, and accurate billing to prevent fraud and waste, allowing us to cover for more people. Because when we're able to cushion on excesses, we're able to now expand our hands to people in other regions. Okay, so we're looking at a situation whereby you as a provider are also an advocate for the enrollee and the patients too. You are the voice of the patient. By reporting their challenges with the scheme, you're suggesting improvements. You're suggesting improvements and you're ensuring patients understand their benefits. You help us refine and perfect the system, because from those feedback and those engagements you have with the enrollee, we're able to also develop on ourselves in a more better way. And finally, we're looking at a situation whereby you, the provider, you are our data superhero. Your accurate and timely data submission is the lifeblood of the scheme. Imputing the right details, imputing the right figures, and giving us the right information allows us to plan and allocate resources and measure our impact, just like we've been measuring from inception. Okay, so on this note, we have actually prepared practical tools and resources to guide you, to progress on achieving universal healthcare coverage. And some of these tools have been outlined here. We're looking at a situation whereby you are focusing on patient-centered care. That is, you're treating every enrollee with dignity, respect, regardless of their plan, which is part of the obligation as a facility. That you also understand the benefits package. You're a master of the different plans, not just understanding it, but being able to guide the patients effectively We're not looking at a situation whereby you're telling an enrollee it's not covered and they're feeling so vulnerable and lost. So you're able to guide them through the process under the scheme properly and relate with us. We're looking at a situation whereby you master the pre-authorization process, which has been streamlined, and emphasizing the importance of both. It's emphasizing the importance of both the patient and for you yourself, and not a situation whereby you tell the enrollee that this process has actually been made to make things even more difficult for you. And finally, effective communication. So there's going to be that constant training on how to communicate with the enrollees about their benefits and limitations, managing the expectations with empathy and professionalism. We're humans. We never stop learning. So this will always be the change game for us. Okay, so on that note, we are not just a commission, we're a partnership. We're not warlords, we're actually in partnership. Let's look at this as a collaboration effect between the government, the people, and even you, our major stakeholder, the healthcare providers. The future of healthcare in Edo State is in this room. Thank you for representing well. And with this, your dedication, expertise, and commitment will not just achieve universal healthcare coverage, we would actually make Edo State a shining example for the entire nation. Thank you for being a part of this project. Let's get to work.
Thank you very much, Ma.
Thank you very much, Mrs. Ify. At this point, we would like to take All right, thank you very much. Thank you, Mrs. Ify, for your presentation. At this point, we would like us to go down for a tea break. There's also an opportunity for people to come together and socialize and network. We have a lot of new facilities present here today who have officially met a lot of the staff for Edohic, and we want you to get familiarized. So at this point, we would like to take 1 or 2 comments before we go down for the tea break. So if anyone has any comments, can you indicate by raising your hand? Okay. So we have Dr. Tokwe here. Dr. Tokwe is one of the pioneer facilities who have been taught from inception till date. Anytime we call upon him, he's always here and always present for us. So we appreciate you, sir. So at this point, we'd like to take a question or a recommendation from Dr. Tokwe. But please, Denise, can we give you a round of applause, please?
We want to thank you for how far the program has been going, talking about doctors using their facility to cooperate with government to make this thing work. I also think that, one, in my own comment, I want to appreciate the work of those who started it. They did a good job. We must not sweep it under the carpet. I also want to say that we also need to know that because of the way it was started, the confidence and the commitment that we have into it, that's why we as providers were able to continue running the scheme even when we were not paid for 3 months. I think that should be appreciated.
Thank you very much.
Because we believe that it's a good scheme. As far as we are concerned, this is the best in the country. There's no other one that compares with what we are experiencing in this state. And we are fully committed to it to make sure that this program will work for our people. So I want to thank the new leadership for what they are doing. And today we listen to the new direction. We believe that this will be a great improvement over what has been done in the past so that the state can move forward. I want to thank you very much for your time. Thank you.
Thank you very much, Dr. Topper. At this point in time, we would like everyone to proceed down for tea break. Like we said, in as much as we want to pass on information to you, we want to also take care of you. We want to also network and socialize with you because our intention is that we should grow this partnership. We should move Edo Health Insurance Scheme forward. So thank you very much. At this point, everyone has to proceed downstairs in an orderly manner, please.
In an orderly manner, please.
Yes. So our break is just for...
This is 10 o'clock. So for the next 30 minutes, we should be down for our tea break. So the mode at which we go out should be in an orderly manner. So those
informal sector for the Edohic and the formal sector. The informal sector covers entails the two broad plans, the bronze plan and the enhanced plan.
So sorry to interrupt. I've just been informed that we want to send a question link to the HSP platform. So you start filling the questions as the presentation. While you listen, you also try to fill the questions. Thank you very much, sir. So sorry for interrupting.
Thank you. Okay, like I said, the informal sector has the paying plans, which is the bronze, the silver, and the enhanced plan. Then the formal sector covers the FOP plan that is for the civil servants. Then we also have our equity plans and other various plans under the Edohic. So the benefit package covers all of this. It's a summary of all the services that is accrued to each plan. Now, this is the sixth edition of the benefit package. Over time, exigencies made us to review it time in out, and officially today we are presenting you the sixth edition. It's updated because of this updated edition became necessary to ensure seamless usage of the benefit package both by the HCFs and even our enrollees. Also, this is the upgrade became also necessary because of the fire cry from our partners as the HCF, because of the tariffs, our current tariffs. They have been outcry concerning our current tariffs. So we had to put all this in consideration, to come up with this sixth edition. Also, we understand that the economic down times like this also affects the government. So we, on our part, when TA was speaking earlier, we also said that we at Edohic also brand ourselves as the financial guardian of the healthcare coverage for Edo State. So it's also imperative for us, to sustain the program. So out of this, we had to also review some of the coverage. So where there were some, we increased our exclusion list in order for us to meet up with the demand of sustaining the program. Then also we introduced. In fact, this part is very important. It's very important because it's a new innovation in this sixth edition. So what we have done with this now, we have capped the specialties. So while I'm introducing the document, we'll see what that means. Thank you. Next slide. Now, we will start with definition of some terms. Of course, we are all partners here, and no one is new to this game here. So because of time, I will just flip through all of this. Next slide. Okay, so I officially introduced the sixth benefit package of the Edohic. It officially was created in May through May till this period, and now, by the grace of God, our amiable DG will announce when it will officially take effect. Thank you. Well, the document is we are all very familiar with this document. However, because of some of the things I have mentioned, which necessitated this sixth edition, we did a lot of touching to it. So I will explain through all that. So from the first column is, of course, the serial number, benefits. Second column is the benefits that have been covered. Then the category of the benefits, either a primary benefit or secondary benefit. Then the class of the benefit, then price. Let's pay attention to price because we did some changes on some price. I will highlight some of the important services that we made changes to. Then the payment mechanism, if it's capitated or if it's a free fee for pay. Then all the plans, you can see them listed out there, and the premium still remains the same. The premium for all the plans still remains the same. We have the informal student health plan, the informal bronze plan, the informal silver health plan, and then the formal health plan, which is the FOP, then the enhanced private health plan. So the first 15 slides actually outlines all the primary services that we cover for Edohic. Not really change much. We only moved some services from secondary to, very few services from secondary to primary. This became important because, like we've been saying and we always reiterate, part of our job is to manage the claims, right? And also to manage the scheme itself. And most importantly, like all doctors here will agree with us, insurance generally is a managed healthcare. It's a managed process. It's not like the way you see your private patients. It is like that globally. So because of that, we looked at some services that we felt like, okay, we had to move those to primary, and then the concept of managed healthcare will be discussed in another forum so that we will not be distracted. Next slide. Okay, it's good. So from this slide, we'll have all the secondary services. Of note, I'm not very good with colors, but I think this is the peach color. So the rows, the columns or rows where you have peach columns, it means it is not covered for that particular plan. You can see that, for example, these first two columns, they are not covered. That's the obstetrician consultation. It's no longer covered for health, for student plan and the bronze plan. Because 1, 2, 3, 4, that's I have no pointer. This peach color is no longer covered for both students and health plan. I will not be able to outline all that is covered or not because of time. So we'll use the color coding to figure out the ones that are not covered. So for all specialties in this 6th benefit package, the obstetrics consultation, nephrologist, please go back. Obstetrics, pediatrics, endocrinologist, cardiothoracic, nephrologist. These specialties are no longer covered for these particular plans. Next slide, please. Next slide. Next slide. Next slide. So what those 4 slides have done is all the specialist consultation that each planner has. Like I've mentioned, those ones are coded peach. Student plan and 18,000 naira plan no longer covers for those specialty. What this actually directly means also is that services under those specialties are technically not also covered, because you can't have someone not see an obstetrician, you expect the person to delivery will be covered under it, because it's the specialist that handles all issues concerning that. So what we have said is, for example, now the obstetrics, everything that is services under obstetrics are no longer covered for these particular plans. Next slide. Okay. Okay, you can see that special nursing care and all of that, of course, is under obstetrics plan, so it's no longer covered for those 2 plans too. Then of note, number 78, general anesthetic, or anesthesia. Before now, the desk officer will agree with us that it used to be, all our surgeries used to be a bundled package. But because of FACRI and in line for us to also improve the tariff, we have decided to also unbundle the anesthesia from the surgery package. So in essence, what that means is, if the previous edition, I think primary CS used to be 250,000, and that was a package including the anesthesia. But in this 6th edition, the amount remains. However, the anesthesia had been pulled out of it. So whenever you are raising your request, if you use anesthesia, of course, you must use an anesthesia. You will not have to also request for it separately. Next slide, please. Next slide. So for ENT, no, go back to the previous slide, please. Go back again. So for ENT services, next slide. For ENT services, majority of the services are covered for all the plans, but there are some specific ones, like antral washer. When we mean specific ones, I would say improved procedures or complex procedures are no longer be covered for the student plan and the 18,000 naira plan because of the tariff. Next slide, please. But basic emergencies in ENT in all the specialties still remain covered across all plans. Next slide. Next slide. Now, for obstetrics, for obs and gynae, it is clearly stated that all the surgeries here are still bundled, except the only thing we unbundled from the package is the anesthesia. every other thing still in that package. So what that means is IV medications used or medications used during a delivery or possibly a cesarean session are still under the package. It's only the anesthesia that is unbundled out of it. Now, I want to introduce this part. I mentioned this in my first slide. Now, all specialties are now capped for all the plans. So we can see that for ops and gynae, for of course, student plan and 18,000 naira plan, ops and gynae is no longer covered for them. But for the other plans, you can see the amount that is capped for a year. So it's important part that we'll be looking at. Ideally, thank God this is a full house. The doctors are also here. So we understand, when we are seeing the patient, we understand what this person may, on the financial part, to understand this is what the insurance can cover for this person. Of course, that will not directly affect our treatment because the patient must get well. However, like we said in health insurance generally, is managed care. So when we have the amount that an insurance is paying for a particular care, it also have a way of guiding our treatment plan for this enrollees. Having it at the back of our mind that we have to give the best to the enrollees, our patients. So for obstetrics, the silver plan, the total for the year is 190,000, 400,000 for FOP, then 350,000 for the enhanced plan. So it means all services, everything the patient will get access to under obstetrics for that year should be under this amount. Next slide, please. So this is what cuts across all the specialties. So general surgery, ophthalmology, dental, they are all capped. We'll see that in the document. Of note, like I said, aside those 18, the student plan and the bronze plan, there are also some specific services that we didn't cover for other plans aside those two. The same reason, it's always the same reason, so as to to control the usage utilization, and also for us to maintain the. Then the next slide, please. Then this for bundles for general surgeries. We can see that there's still the same cap for all the plans. And for general surgery, it's covered for all plans. This is because there are some presentations that are dire emergencies, and of course, if you don't do it, it can result to mortality. So because of that, there are some specific surgeries or interventions that are covered across board, irrespective of the plan. For example, an expiratory laparotomy is covered across all the plans. Same thing with next slide, please. Same thing with appendectomy, herniorrhaphy, because we know these are basic life-saving procedures. Then outside that, complex procedures, not necessarily not just complex, elective or code procedures are not covered for, not just even only the student and bronze plan, even for some of our other plans like the silver plan. Hemorrhoidectomy, things like hemorrhoidectomy, prostatectomy are no longer covered for those plans because we know they are code plans, they are code procedures. Technically, they are also almost a procedure you can do with or without. Thank you. Next slide, please. Next slide. Okay. So for internal medicines, bed space and all still remain the same. It's still 10 days. But we also know that bed space is under primary. So, but if you have a patient referred to you, it now becomes imperative for you to actually know the actual number of days the patient is entitled to. Next slide, please. Okay, for orthopedic surgeries, majority of them are actually covered for only the civil service, the FOP and the enhanced plan. Next slide. Next slide. You can see that basic orthopedic procedures are covered for across all the plans, like passage of cast, removal of cast, and all of that. They are covered across all plans. And especially for student plans because of their age group. So that's covered for all of them. Then you can see that circumcision is never covered for bronze and student plan because obstetric is not covered for them. Next plan, please. Next plan. So, okay, for optometries, please let's pay attention to the capping, the annual capping for this. Whatever service we are doing for any of these plans should align with the annual capping for them. And then of note, glasses is now still 1 in 2 years. It has always been 1 in 2 years, and is now one for a family for the civil for the FOP plan. Is one per family. Is one per family in 2 years, every 2 years, and the amount is stated there. Next slide. Next slide. All right. Next slide. So for ophthalmology, basic surgeries, most of the services under ophthalmology are also not covered for both the students and the 18,000 naira plan. Next slide, please. Okay, dental care, the capping is also stated there. And most of the plans here are covered for all the plans, most of the services here. Next slide. Next slide. All right. So all our investigations, we really didn't do much in the investigations, but like I said, some had been moved to primary, which I already mentioned that. But all other plans, all other investigations, they are still there. However, there are some specialized investigations that are no longer covered. There are some specialized investigations that are no longer covered for both the students and the bronze plan. So when we get the documents, we can see all of that. Next slide. All right. Okay. So for radiological, basic radiological investigation like the chest X-ray, abdominal and pelvic ultrasound scan, those are basic investigations. So they are covered across all plans. Then next slide. ECG also is a basic cardio investigation, so it's also covered across all plans. Okay, for obstetric care, please just leave this. For obstetric care, of course, ANC is no longer covered for these two plans and all of that. So this from 343 to this last part of the benefit package gives us a summary of common or regular routine services that's being carried out. So it just shows who is covered for and who is not covered for. Next slide. So that's the end of the document itself. However, my senior colleague will come up and discuss further. So please, for antenatal care, I will run through this because of time. For antenatal care, ANC registration still begins at 12 weeks, as it has always been. And of course, it's a bundled. The ANC is a bundled. It includes two ultrasound. It includes the specialists, of course, the specialists and the follow-up, and it includes the booking investigations. Then deliveries are bundled as it has always been, but it's 2 every year and maximum of 4. Then CS delivery is only covered, is now covered 50-50 co-payment on silver plan and fully across for formal and enhanced plan. Please, this is very important. Then the neonate is covered for the following. This. So next slide. Okay. Co-payment of. So anesthesia is now on board from all surgeries, so right. The, very important, this is a new one. All surgeries, ANC and delivery had to be done 6 months of enrolling into the scheme. This part is very important because the enrollee usually come in contact with us, the desk officers. So it's from your end that you detect these things. so that we'll not run into issues while we are raising claims later. It's very important. It is a standard policy for us now that all surgeries, including the ANC, can only be done, and enrollee is entitled to also to these things 6 months, after 6 months into the scheme. So what that means in essence is our very first point here is ANC cannot be registered 12 weeks into the scheme. That's 3 months into the pregnancy. So if you are already pregnant, you cannot almost get a plan. That's what this means. Because by the time you are doing a surgery also, God forbid, if you had to do a CS or a surgery for someone that is already pregnant, it means the person must have been on the scheme for over 6 months. We'll work it out. Then enrollees are entitled to see a maximum of 2. I'm stating this now because there's a tweak in this. It used to be 3, but now it has been reduced to 2 maximum of the enrollees are entitled to 2 maximum of specialists, 2 specialists in a year with 2 follow-ups. It is very important. The enrollees also these documents are public domain, so the enrollees also they are privy to this information as well, so they know. So enrollees now they are entitled to 2 specialists in a year with 2 follow-ups. Very clear. So please let's also help us to monitor this. Therefore, selected cases of referrals and it's a lot of this for referral centers. It's self-explanatory. Then the services not currently listed on the benefit package are regarded as services under exclusion list. So what exclusion list means is services under the exclusion list are services that are not covered under the insurance. And this is the list, right? Apparently, this is a global policy. Most of the things here is a global thing for beautification procedures, and are not usually covered under insurance. Then for us here in our environment, some of these things like HIV, TB, there's already a grant, or let's say grant, there's already a program that covers for all of this. There's already a subsidized management for it by the government. So we cannot duplicate a government program. So some of these things, like the TB, HIV, vaccination, these things are already being subsidized, so it's not covered. Then blood transfusions, because of the ethical issues associated with it, is not covered by the insurance, and every other thing. And then anything that is not covered on our document is part of this exclusion list. Thank you very much.
Thank you very much. Thank you very much, Dr. Fetiro, for that presentation. This presentation will lead us to the next presentation, which will be carried by the head of Claims Department, Dr. Obey. She will tell us more on the efficient claims management. And please, I want to reiterate that the link that was sent to us earlier is to entertain questions. So any question you have, just put them on the link. Then at the end of every section, we're going to attend to your questions. Thank you very much, Dr. Obey. The floor is yours.
Good morning, everyone. Standing on existing protocol, my name is Dr. Obehi Egbado Saze. I'm the head of Claims Department, Edo State Health Insurance. And today I'm here to talk to you about efficient claims management. But first, let me tell you a story. In a small town, a group of kids decided to build something for themselves. And they decided to build a neighborhood Zobo stand. So while they built this neighborhood Zobo stand, they decided to have a funding that they called a Zobo fund. So for this fund, each and every one of them, with the money earned, they contributed into like a pocket. And so they did this, and this was supposed to help them in cases or in times of contingencies. So over time, when someone had a need, maybe they needed to change a jar, or they needed to restock on supplies, or someone got burnt from cooking the zobo, the person needed to maybe see a doctor, this fund could come and help. And it was running smoothly, and it was good for everyone. And after a while, some kids started to take advantage of this funding. At first, one of them said, "Oh, my jar got broken." And that was a lie, but she was giving money to replace the jar. After a while, someone else came and said, oh, my Zobo leaves and spices have run out. Whereas that person sold his leaves to someone else and then he got money from the funding. Another person came and said, oh, I got burnt and I need to see a doctor. And he was given money. And little by little, the funding drained and it finished. And then there was a strain. People who really needed to use this funding now didn't have this funding to use. So at that point in time, they had another meeting and they decided not to scrap the Zobo funding, but instead they will put checks and measures in place. They will ask questions, they will keep records, they will keep this funding to the health insurance where put in money to be able to cover for health emergencies and help to reduce out-of-pocket expenditure. And this was done not to punish the people involved, but to be able to keep a promise that has been made, the promise of care. And this promise of care we can't do on our own. We need you, our esteemed partners, to help us with this promise. And that has led the Commission to design a standard operating procedure that will help guide our funding and bring the best out for our enrollees. Okay. So we all know what an SOP is usually. Is a guideline that helps to streamline processes in organizations. So for us, this is our process that helps to streamline our processes. So basically, our SOP, what we want you to know is that, first of all, you have to treat our enrollees for their consultations, their investigations, their drugs in line with our benefit package. That means that you give them services under our benefit package, you give them their coverage under our benefit package, and you make sure their pricing tallies with our benefit package. Okay, and then when it comes to emergencies, we already have a standing policy, which I'm sure most of us are aware of. First of all, an Edohic enrollee can walk into any Edohic accredited facility in time of emergencies. That doesn't necessarily need to be the enrollee's main facility, but if it's an emergency, he or she has the right to walk into that facility and care should be rendered. Secondly, in cases of emergency, we don't expect you to start waiting for pre-authorization code. We expect you to go ahead and stabilize these patients, and then you reach out to us in the next 24 hours. Thirdly, like we said, it's very important that during times of emergencies, because we have situations where facilities send mails saying, oh, it's an emergency, we're waiting for authorization code. There is no need for that. As far as your doctor has said this is an emergency and is seeing clearly that the patient is having an emergency, please go ahead and treat. All you need to do is place a call across so that we are carried along in the process. So we have also outlined an emergency care policy, just so that you are clear on our stance on emergency protocols. So for emergency, an emergency is any life-threatening medical condition or sudden illness requiring immediate medical attention to prevent death or serious impairment. This includes, but not limited to, the examples listed here. Also, like I already said, for all enrollees, our enrollees should be stabilized before pre-authorization code should be requested for. And then you notify us within 24 hours. It's understandable that for emergencies, it should be a retrospective authorization that will be gotten. But one of the things that we'll ask for you or from you is one of the following things. We'll definitely ask you for the patient's insurance details. We need the patient's name and CIN to ensure that these enrollees are enrollee. And after that, you will either be giving us one of these things, either a clinical note, lab, or a scan investigation. And then for emergencies done, they will be billed in line with our tariff on our benefit package. And then the enrollees are also advised to reach out to the Commission within 24 to 48 hours. And when they can't do that, a relative can do that on their behalf. Okay. Please, next slide. Okay, so for non-urgent conditions presented as emergencies, for convenience may not qualify for emergency cover after clinical review. What we mean by that is we've had cases where enrollees have called that, oh, I was having an emergency, I had a toothache, it was so bad, went to the hospital. But on looking at the request, we're seeing scaling and polishing. I'm sure you can all agree with me that even if that enrollee has said he or she was having an emergency, scaling and polishing is not a life-saving procedure, so that will not qualify. So to our authorization process, an initial authorization code must be obtained from the department before specialist consultation services are rendered. I think that makes sense. So first of all, as long as it's not an emergency procedure, you must get an initial authorization code for treatment. And for specialist consults, we don't want a situation where the enrollee has already seen the specialist and then you're asking us for code and we're telling you it's denied. Who pays then? So it's important you ask for a pre-authorization code. This authorization code will be valid for the initial consultation and must be quoted for follow-up visits. So now it's important that you always include that initial code that was given when asking for follow-up visits and drugs. This helps us for continuity and to track the process. All referred specialist care must reference the authorized code given for that service. Now, usually, you're supposed to send us, once we are admitting a patient, we should be aware. Just like I said with the specialist consultation, we don't want a situation where you've admitted a patient and gone ahead with treatment, and then we are telling you some things are declined. It doesn't look good on both parts. So it's best you let us know, notify us about this admission before going ahead. This next slide. Okay. So also the commission, I'm sure most of us are, this is not foreign to us. We've started using this for over a month now. It was designed by the commission and has been working effectively for us. So, but I'll just go over it again just for clarity's sake. So first of all, the authorization request is sent to the claims department of the Edo State Health Insurance Commission. And then you include the dates. So for example, if it's today, you write today's date. And then your request type, is it a pre-authorization? Is it a retrospective authorization? Is it a referral request? Whatever it is your request type is, you mention it. The enrollee's information, this is very, very important because first of all, we need to identify that this enrollee is our enrollee. So the enrollee's name, mobile number, CIN, very important. Date of birth, sex, and weight. This also helps us and guides us with to know the service, that these services you are giving our enrollee are streamlined for them. Also, we'll ask for provider information, rendering physician, the name of the physician seeing this patient, and if needed, the specialty. After that, you give us the diagnosis. If a procedure is being done, you let us know the procedure. For description of services, we have detailed description of the requested medical service. So for example, if it's just drugs, you give us the prescription. Don't just write artemether times 3. Please let us know the dosage and for how long you're giving it. For procedures and specialist consultations only, we might ask you most likely for one of the following: a clinical note, laboratory results, radiological reports, or the physician's order. And after that, the desk officer signs with their name and their phone number. Okay, so this is a live example of mails that we've gotten that were rejected. So you know why they were rejected. And so if you make those mistakes, you correct it. So if we look at this first one, we have blocked the enrollee's name and the facility name for the sake of privacy. So this request was sent on the 7th of June. Okay, so the name, phone number, CI, and date of birth was put. Is a female weighing 40 kg. The name of the doctor was put. Is a GP. Requested services. The diagnosis, query measles and recurrent chest pain. And the service requested for drugs was cefuroxime tablets. Now, we all know that measles is a viral infection. So if you're going by this diagnosis of the measles, there's no need for an antibiotics here. Even with the recurrent chest pain, that's all that was said, recurrent chest pain. So from this request, We cannot on our end see why the enrollee needs an antibiotic. So it was declined. Okay, so this is another one. Another hospital, the request was for an investigation. Also, they put the name, date of service, enrollee CIN, age 43 years, gender male, and then the diagnosis is saying heavy menstrual bleeding. Do you know, these are the things we see. And then even in the clinic, okay, the person went further to explain the clinical state, which is good. And the person told us no frequent urination. And the person comes on there and says service required urine MCS. So you see, and sometimes when we try to reach out to the person to say, please, because it's not our job to tell you how to make your request, but because we are passionate about our enrollees, sometimes we even reach out or send a message, okay, kindly go through your request again. Some of you tell us, hey, people don't want to approve. If you don't want to approve, I'll just tell the enrollee you don't want to approve. So please, whenever we say, kindly look through your request, just know that I'm giving you an exposure, just know that there's something wrong with that request. Okay, please. Okay, so we've also designed a care guideline just to let you know how we operate our processes and how we like our release based on what we have, resources we have, how to utilize it best. So for the specialist care should be limited to the reference care needed, e.g. endocrinology consult should not be used to treat upper respiratory tract infection or malaria. So what we're saying here is, for example, the enrollee is referred to you to the endocrinologist to manage high blood sugar. Please, if the enrollee is having malaria or cough, the enrollee can go to his or her private facility or her primary facility rather and get the malaria and cough treated. The enrollee was referred to your hospital or your facility for endocrinology. Please, I hope that's clear. So visits by enrollees to review results of just investigation requested by the specialist would not form part of follow-up visits. Okay, so we've had the need to mention this now because we've noticed that an enrollee can come to a facility today and a code is given to see, for example, the endocrinologist. And the enrollee sees the endocrinologist. And then the endocrinologist has said, go and do HbA1c. And she goes, let's say it's a lady, she goes to do the HbA1c. And she's coming back with the results. And on coming back with the result, the facility is requesting for second follow-up visits for that enrollee. And it shouldn't be so. The doctor has seen that investigation result review is still under that first consultation. It shouldn't be charged as a second consultation because doing that, you're also depriving this enrollee. Because the enrollee reviews two results, the enrollee has no access to that endocrinologist. Let's say the person can't even afford it out of pocket. That's the end. So please, let's take note of that. Yeah, each request for consultation will cover all reviews of medication and investigation. I think this speaks to that. So, guidelines. First, to severe pain. When it's really stable and you understand why some drugs, you shouldn't be giving some drugs for a very long time. For example, I also put that money here because we like to put that money here. You give people that money, give it for 4 weeks. Give it for 6 weeks. Please, no. Go on and give it. I don't know what they are putting in. So, I just like that. I can see all put that money. Please. You said this one is malaria. Giving injection. The thing that you're saying, that's if you want to give this put that for malaria, please, something like that. So I think was that disease. After confirmation of the HIV test,
But the triple metronym that's what the main result was see the third result metronym was but it's when you get there, so like I said, now we have social communication and follow. If they say I don't know following social communication, it's back to their priorities to get there. I don't know if it's understanding the way it's hard, don't know, they really don't go back for your okay, already referring the transaction of that and then referring sentences that was easy advertisements. This person has to carry out so much when we are tested, you wrote out some sentences that you have to carry out. So we don't expect those sentences without any form of communication. Then when you refer it, it's 25% of your income tax appropriate transaction. So what we're saying, we're understanding you how to make changes. That's what we're saying is technically to also if we don't know that very what high extent of your realization, the transaction. So, we also said education and things for referral mistakes. So what we are getting out, for example,
Those customers are relationship. they are economic customers, employees, or they are your patients. Every time I have the opportunity to engage and emphasis, I always stress this point. Until you see them as my own, you will not give them the best of service that is required. That is very important. That's why I think so patients are focused in the setting every health facility. You open the hospital to get them to care to patients. Alright, so at the setting of systems, whether be sustained dependent on how patients are handled. Alright? So everything that concerns their interactions with us when they are assessing care should take into account because they are the reason why that science exists. So these are aspects that are just very what is that patient experience? What is that talking about? What's patient experience? It is also about interaction that the patient has following entrance into your facility. So when they leave and when they are followed, all that interaction, that's also patient experience. So it includes processes, your reception, your medication, your communication style, the waiting time, the kind of medical personnel that is attending to them. Yeah. You must do so well. I believe that every practice is very should intend to achieve for this period of time, and then you monitor it so that if you are not improving, you change your strategy. You know, something to what's better to get improvement. Then feedback and continuous improvement. Like for us in the Edo State Health Insurance Commission, we take feedback very importantly. We call them release that use your facility. We usually reach out to them to get feedback from them. You should also do the same so that you know exactly how you are doing, whether you are improving or whether they have issues about you. You can get that information. Um, so these are principles that will guide us. This slide is going to be shared with every one of us so we can really get through all of this. Let's just go to grievance handling very quickly. So these are some frequent type of grievance issues that we have had to deal with in the commission. When we say grievance, it is any formal or informal. It doesn't have to be written. As far as it is a complaint that an enrollee has brought out to express their dissatisfaction, that's what we are looking at here today. All right. So these are different types: billing issues, rude or unprofessional behavior. You are working in a service industry. Professionalism must be top notch. All right. Referral challenges, errors in drug dispensing. That's why paying attention to details is very important as a service personnel. Unavailability of medical records, poor communication, miscommunication, verbal and physical abuse. They are quite much. Let's go to the next one, please. What to do when you have people, enrollees giving you complaints or raising complaints. Receive and acknowledge what they have said. Don't just throw it out. Investigate where you need to and resolve them where you need to resolve. It should not end up with us and then we now come back, compliance follows us, claims comes, and we're like, what happened here? It shouldn't always get to that. You shouldn't always get to that, actually. Then where you cannot now handle, of course, escalate it so that the parties that can do so will do so swiftly. Then communicate resolutions and record your encounters properly. Then what you can do during grievance, please try to stay calm. I always say this to all service officers when I have to deal with them. All your complaints or any complaints you are getting from your patients, please don't take it personally. Once you begin to take it personally, you begin to react in the wrong way. Don't take it personal. The person is not feeling okay. Don't forget, the person is already sick. All right. So that alone has disoriented the person. All right. So if someone is now screaming at you their frustrations, don't take it personal. Stay calm. Control your own self. That way, you'll be able to control the situation better. Be professional, show empathy, accept and apologize where you need to. We have gotten feedback from enrollees telling us that the staff was so rude. This was so rude to me. How can? I'm like, sorry, sir, don't be angry. All right? It's because of how the person perceived your reception of what he or she has said to you. Things you should not do, please don't argue. Don't blame. Don't delay response that you have gotten. We get this a lot. Sometimes we get complaints from a release that they've not responded to my approval. Meanwhile, it has been approved many minutes ago. Please don't delay the response. Give them a response so that they know that they've been sorted out. Don't walk out of a patient except your life is threatened. But we know our patients are nice, they won't do that. But don't walk out of a patient, okay? Don't shout down on a patient. They are important, so take them, treat them respectfully. So I think that brings us to the end of this communication this morning or this afternoon. So please, like I said earlier, our patients are our partners. They are the reason why we are in business. If you see them that way, you will treat them better. Thank you.
Thank you very much. What point is I am made? I want you to say, what head facility say, you are doing a release giving us energy. You are doing a release something our facility. Something has come up time and time again. But I keep correcting you and I say, they are not our release, they are your release. They are not our release. We don't assign them to you. They are your release, they are your release. And for every release, kind of translates to resources for you. So the more release you have, the more financial backing you get. And also bear in mind that the easiest way to spread information is word of mouth. You see teachers, once you do one teacher something wrong, you have done it, you have offended us with all teachers. So every time you carefully come out and say, please can I change percent? Can I go to your store facility? My colleagues say you go that place, you manage it very well. You get to they give you to make me listen to them. You have to speak back everything you find from teachers, from pensioners. But guess what? We don't manage your release well. They'll come back and say, me and my colleagues, we won't. And once they move, it means that your resources also moves with them. So you must manage your enrollees to the best of your expectations. Are we on the same page? Are we on the same page? Please, you must care for your enrollees. You must manage your enrollees. They are your enrollees. We just assigned them to you, right? They are your responsibility. So please, going forward, we expect that you do better. And on this note, we would like to invite the last facilitator. We call her the policewoman of Edohic. So she's going to come and remind us on things that we should and shouldn't do, sanctions when they apply. I know here we are not always on our best behavior. We usually don't have our for but the truth is we prepare ourselves to fight our what's wrong. We have to invite the last speaker for the day. It starts Maria working on.
Good morning, everyone. Standing on existing protocol. I'm Osas Maria Ogbeide Hama, Esquire. Most of you call me police. I'm happy to see your faces again. Okay, the compliance department, like you all know, is to enforce. All we do is to, you see these SOPs, the law, processes, what we do is to ensure that you comply respectfully. I would like to stand on Dr. Obey's story. You see, when things were going haywire, they had to bring in rules, regulation to ensure that they save the day. Our work is to implement, to ensure that those rules are followed to the letter. Next slide, please. So these are issues of priorities to the Commission. Number one, healthcare facilities who fail to onboard or renew the enrollment of their staff on the scheme. Like you all know, it is not Edohic, it's not Edohic, just bringing out rules from nowhere. These rules are backed by law. We have the health insurance, the National Health Insurance Act, the National Health Insurance Authority Act. We have the Edo State Health Insurance Act. We have directive of government backing this policy. And it states that once you carry out business in Edo State, you must have your staff enrolled on Edohic, which means this rule is not just because you are partners with us, but even for operating in Edo State, you ought to comply. Number two, healthcare providers who charge enrollees above the stipulated 10%. We have had a lot of complaints on this, and you will agree with me that for facilities who have erred in this regard, we have made them reimburse, refund those collections, those monies to the enrollees. We do this not because we do not love our partners, the facilities. Don't forget, it is a tripartite relationship. You have the commission on top, and the wedding between the facilities and our enrollees is conducted by the health insurance. So we try to balance our compliance in such a way that we are not beating facilities for our enrollees, and we are not beating enrollees for facilities. So there must be a balance. So when it comes to charging enrollees above the stipulated 10% on paying plans, our reputation is already at stake. We have made a promise to our enrollees, and we rely on you to help us accomplish that. So whenever you charge more than 10%, you are telling them that Edohic, don't tell una lie, is more than 10%. So please, if you have an issue that has to do with payment, like they said from the claims department, reach out. Reach out. Don't charge our enrollees above the stipulated payments plan. Number 3, healthcare facilities who collect payments from enrollees under our free healthcare, the equity plan. For some facilities, your secondary care centers. We have had complaints, and we really, really frown at that. You see, these enrollees are vulnerable. Like our able DG said, nobody is left out in the health insurance scheme. So when we bring them in and hand them over to you to treat, to handle, we expect that you also respect the terms. They are vulnerable residents of Edo State. They shouldn't come to your facility and you now require them to pay for something that is fully covered. The Edohic will not appreciate this. Treating enrollees as cash-paying patients, yes. This one, you will wonder why it's repeating itself. This is another scenario. That is, for some facilities, they even require to pretend not to know that this is especially for emergencies. They know that, wow, it's a time to cash out. This enrollee is apprehensive. Good. They pretend not to know that this enrollee, even sometimes, enrollee will tell them, I'm on Edohic. I'm on Edohic. These facilities will go ahead and treat them as cash-paying patients. That is with no regard to their status as enrollees on the scheme. We have had to make facilities refund 100% what they collected. And we don't want to come and harass you. Just comply. You know, it's easier to comply. The relationship is seamless like that. Then number 5, not referring enrollees to accredited. Good. Enrollees to accredited. You know, we have accredited pharmacies and diagnostic centers. We have had course too to address issues of a facility giving an enrollee referral to a private diagnostic center. Go there, go do your full blood counts. Our machine not dey work. I personally experienced that. Personally. So this is not just enrollees bringing reports. This is because we also go from time to time, we monitor. I can come to your facility, not even dressed as by stati, as police. I just come in as an enrollee to watch what you are doing. We monitor a lot. For those of you who know, we monitor a lot. And that is not supposed to be. If genuinely you cannot give that service at that time, you have to refer them to our diagnostic centers. You already have the list of that in your facilities. Then the 6th one, healthcare providers that falls below standard. Yes. Like Dr. Yuki said, our Q&A activity, you are aware, they come around from time to time to look at it. The report comes to the compliance department. And when you are found wanting, we will have to apply the law. And you know, in applying the law, it means we have to ask you to do what you ought to do. But you know, our compliance in Edohic, we have a human face to it. We have a human face to it. So it's not all about kill them, comply. We don't care, comply. No, you all know that we have a human face to our enforcement. So our enforcement action is proportionate to the severity of breach, acknowledges public interest and community impact. Like I said, it is not all about comply. There is a result we are looking for in that compliance. Now, we don't come, like they say, use hammer to kill a fly. No. We give out our sanctions based on the breach. So it's not like you did not attend to our enrollees on time. And we say, okay, go on remediation. No, no, that is not how we do it. And you know that this is health insurance. It is not just any other. Health is a very important part of every human being. And that is why you see the public interest there. So this is our enforcement action plan, the stages. So when it comes to enforcement, what you get from us first is a notice of non-compliance. And for facilities that have received a notice of non-compliance from us, you will agree with us that we have had, before that happens, we must have had several informal engagements with you to see exactly what the problem is. And when we find out that it's like you are not ready to move forward with us, we formally notify you of your non-compliance status. Refund, yes, order of refund. Like I said before, for enrollees that you charge out of pocket or above the stipulated 10%, you will be required to refund. And for those who go further to destroy or attempt to destroy the commission's reputation, fine may apply. Look at your operational guidelines, these sanctions are there. Then prosecution, yes. If an enrollee is mismanaged, like she said, the authorization template is for us to also monitor what is happening to our enrollees. If an enrollee is mismanaged, it leaves our purview. It goes to criminal law. We have a responsibility to also help the health ecosystem. So if a facility mismanages our enrollee and it gets to that point where this is an outright breach of medical ethics, that facility will be reported to the appropriate quarter for the right action. Next slide, please. Yes, the Commission intends to continue to provide support to facilities genuinely having challenges with compliance on the scheme. And in doing this, we conduct training, just like the one going on now. From the report of the QA that was submitted to the DG, the DG with a good office has ordered this training. And this is to reinforce our SOPs, our information from the health insurance. This is what we want from you. In case you are mistaken, this is the direction we want you to go. That is exactly what is going on now. We undertake advisory visits. Like I said, we do a lot of informal visits so that we can actually find out what the problem is and know how to resolve it. Workshop just like the one going on. We also conduct specific trainings for specific facilities having a specific type of challenge. This is to ensure that the facility has no excuse not to comply. We offer alternative dispute resolution. Yes, we have had cases where an enrollee will come and say, hey, Edohic, I don't want that facility again. The way I was treated, you need to see the way the desk officer was talking to me, and they say, we are not going there. So it is under this dispute resolution that we encourage the enrollee to go back. That's just go back. They have been managing you. This is just a misunderstanding. So we do that. Then we also issue advisory notices. Yes, circulars, just like the one you get on the HSP platform from time to time. Next slide, please. The Commission intends to target repeat offenders where their conduct falls short of the standards set by the Commission. And repeat offenders, you will agree with me, should not be on the scheme. It means you are not ready to bring the vision and mission of Edohic to light. So that means you are not ready to partner with us. And it's never interesting. It's never interesting for us. We have had to delist facilities. It's never an interesting situation. We would rather make do with few facilities that are ready to comply and help us grow than to have a lot of facilities that will keep receiving complaints from. So for repeated offenders, our lovely advice is that please come up to speed. Yes, the Commission intends to continue to monitor compliance and investigate cases of non-compliance in an informed, yes, we inform you of exactly this transparency in a timely manner. Where the Commission discovers that a stakeholder is well informed but refuses to comply, please go to the next sanctions to apply. We want to sincerely, with the kind permission of the DG, thank those facilities that don't give us stress. You see, enrollees come to us to say, you see that A and B facility, oh, they're too